A functional physio approach emphasizes objective measurements of loss for activities of daily living, fall prevention, and fostering of patient autonomy. Functional means based on function, which is what do you need to do. Also, patients must be safe, which is fall prevention, and don't make things worse, which is what I'm calling fostering patient autonomy. This functional approach to medical decision-making comes from systems thinking and reasoning from first principles. By this, I mean to say that we have to embrace the complexity and the uncertainty of patient care. There are many different ideas about clinical decision-making. I've worked with a lot of different physios, a lot of different backgrounds. For good or for bad, physio thinking is all over the place. There are some common approaches, but these have their limitations. Let me go through a few of these so you know where I'm coming from. Some physios use a patho-anatomical approach. They're looking for that offending tissue problem. But think of low back pain. What tissue do you think it is? Yeah, next time you're in the lunchroom, ask a bunch of physios, what tissue causes low back pain? Watch the sparks fly. There are some other good physio approaches, like Shirley Sahrmann's movement system impairment approach, or the McKenzie Method with repeated movement testing and directional preference. Or more recently, O'Sullivan has championed a biopsychosocial approach for chronic low back pain. Or one of the older developmental approaches like PNF or Bobath's NDT, which are useful for neuro and pediatric patients. But I don't see how something like DNS applies to patients that I'm seeing, like after a wrist fracture, or somebody who's falling, or after an ankle surgery. That's the problem with many of these approaches. They're very niche specific for certain situations. If they work for you, that's great, but I only pull them out when I need them. Now that I've insulted everybody in the physio world, let me tell you about my approach that's simple, practical, and will work with pretty much everyone you'll see. It's a functional approach with 3 pillars. The first pillar is an objective measure of loss for activities of daily living. So you measure daily living. It's important to prioritize objective measures over pain and subjective feelings. There are 2 levels of measurement. There are the high-level tools, and then there are the more specific clinical measures. For high-level tools, I like the CATS index, the functional independence measure, and the Barthel index. They're simple, they're quick, and they're free. For specific clinical measures, I like active range of motion, either using your eyeball or a goniometer. I like strength testing with manual muscle testing, and I like the FMS, the functional movement screen. If you're not familiar with the FMS, then Google it or look on YouTube. There's tons of free resources available, so don't spend any money on it unless you really have to. And maybe you only need part of the FMS. That's great. Then test the part that you need and then retest. That's the beauty of this system. Identify what pieces of the puzzle are missing, measure where you're at, do your treatment, and then remeasure, adjust, and repeat. Some people will cringe when I say this, but your feelings, your pain, meh. A functional approach means you measure an objective loss. You focus on restoring activities of daily living or job duties or some other purposeful task. Be specific with what you're doing. This is where those ADL tools will help focus you on what's important. You got to start with dressing and bathing and eating, progress to transfers, ambulation, and stairs. Everyone loves icing on the cake, but this stuff is cake. You really can't just eat the icing. The second pillar of this functional approach is fall prevention. If you have to start in sitting, then start in sitting. I've seen sitting balance more of a problem with neuro patients than with ortho or geriatrics, but you need sitting. Then sit to stand, then standing, then weight shifting and stepping, and after walking, it's stepping up and stairs. Everyone is going to say this is obvious, but this is an approach whether the patient came in for low back pain or had a knee surgery or had an ankle fracture. Because sometimes patients have 2 things or 3 things or more things. Life is messy and patients don't always choose their problems and we don't always choose our patients. So that's why this second pillar of my functional approach is called fall prevention. Everyone needs to get up and get going safely. Falls are common, and sometimes when we see a lot of them, we think they're no big deal, but they are a big deal. Falling causes pain and fear. Falling causes fractures, head injuries, death. Being unsafe at home means people may not be able to stay at home. This leads to a huge number of issues with family, long-term care, quality of life. But the physio part of this is fall prevention. We need to do what we can to keep every patient safe wherever they are. The third pillar of this functional approach is what I call fostering patient autonomy. This is similar to fall prevention we commonly see in seniors. It's the importance of a healthy lifestyle, not just with these visits and this episode of care, but also sustainably into the future. So it's more than getting OA hips and knees into a functional home program or preparing them for a joint replacement. Patient autonomy has three elements. First, injury recovery with an eye on prevention. This is the problem of incomplete rehab, like needing to help with ADLs after an upper extremity fracture or ACL re-tears. The second part of patient autonomy is managing chronic conditions. Osteoarthritis and diabetic neuropathy are never going to get better. They need to have education and a long-term home exercise program. The third part of patient autonomy is healthy lifestyle elements, like risky sports, smoking, regular walking to stay active. Many common health problems respond to exercise, so we need to address it. I didn't wake up one day and decide to create my own flavor of physiotherapy. This stuff isn't even unique to me. All this is a result of seeing thousands of patients over the last 30 years. After seeing some common themes over and over again, let's address what we can measure. Let's be sure that fall prevention is the cornerstone of everyone's program. And how do we set our patients up for a better future? So my functional approach here is about being practical and looking at the big picture. Too often we get caught up in the day-to-day. Physio can be a job, but it can also be a calling. So if you're so busy with the day-to-day grind, I'd encourage you to step back and take a wider view of things. Physio lets us work with some messed up people. Others are just a little off course and need a nudge. What little nudges have you used to help your patients stay healthy? Let us know in the comments below. My 2 books are now available at Amazon. What They Don't Teach You About Documentation in Physiotherapy School, a short how-to manual for successful daily note templates, and From Injury to Recovery Through Exercise, simple functional exercise progressions for physiotherapists to restore lifting, standing, walking. Thank you for your support. Watch another video right away or subscribe to see what else I have. Thank you.